Orukungane rw'ebyamagara ogwa Kigezi yona gwakoregwa omu district ya Kanungu. Orukungano oru n'orw'omwaka gwa kashatu ogwayeta third Kigezi Annual Regional Performance Joint Review Meeting. Orukiiko oru rwayetabamu abahangu omu byamagara abalimu ba commissioners, directors, bakuru b'abakozi, RDCs, bakuru b'ebyamagara omuri Kanungu, Rubanda, Kabale, Rukungiri, Rukiga hamwe na Kisoro. Kanungu Express TV nekwisaho byona uko byagenda omuri Kihihi Town Council ahari Goro Cottages omuri district ya Kanungu.
And they are inevitably will get some delays along the way. Thank you.
Okay, Team Rukunjiri, we shall give you a moment to summarize when that time comes. Let's invite let's first thank them as we invite Kabale. As we invite them, invite Kabale to give us.
Are you the one presenting?
Is invited because he gave birth to Rwanda.
Okay.
Offer preventive services and you want the OPD attendance to double. So we had the same engagement. Actually, the modifications we have now partly is because of some of those engagements we had with them. However, let's take it that there is still unmet need. So sometimes, if everyone who is eligible to come to our OPDs, who is eligible to deliver from health facilities, would come, those numbers will improve, by the way. I can assure you. We would still have an increase because they are still unattended. The cases who deliver there in the communities, those who come when it is too late, if everyone was coming to do, for example, screening, as the Director General said, those numbers would improve. Okay? But logically, you can see that it is inversely proportional, if you remember the mathematics. There was a question about leishmania and those other neglected diseases and leprosy. The surveillance focal persons, Rukunjiri, where are you? So the
place, Kakomo, that one was also mentioned. At least you are making some progress now.
Issues of maternal mortality, because we found actually down here in the sub-counties neighboring the national park, so many mothers are delivering from home. Before we said that if we improve services in our facilities, mothers will come. Yes, on one end, I think that could be true. But the other, which we have been talking about, community engagement, is still lacking. And we talked about it here. You know, the use of we talk about health promotion, disease prevention, but not much is actually being put there. How much have we empowered the health assistants, the health educators to do their work? So for me, I want us to take it from that angle. We empower the population to demand the service, because alone we shall not manage. Did anyone really raise any issues to do with health? Nothing. So we cannot fight this alone, and we need that community action. And for me, I would say some of these things, I would want to summarize it here and say, let's implement the national community health strategy, let it not keep on paper, and most of these things will be answered. I thank you.
Okay. I think those are submissions from
something like a data issue. I think we have to look at it more critically. But on the issue of lymphatic filariasis and the hydrocele, last year there is a retired doctor called Mukone. He had an interest in looking at lymphedema. So he came in Rukunjiri and was doing some sort of like a survey. And there are cases he was able to pick. especially from those who are involved in mining and so on and so on. So the issue of leishmaniasis, Jude, is something we have to go to look at as far as our data is concerned. Because with our data entry being centralized at sub-district level, most likely someone could have made an error because this is outright out of the scope. On the issue of labs, Jude, my boss, what is a lab?
We are talking a lot for on primary health care, disease prevention and health promotion, and it looks like we have not had the occasion to discuss matters to do with community health extension workers in this area, and yet this was tried out in many districts. Seems to work. Two is to I think this is to Kanungu, Kambuga.
That were raised. One is on maternal day, being contributed by Kambuga. But as you know, Kambuga is the referral facility for the district. So anyone who is really bad off is sent to Kambuga. So that's why they will die. And if you look at our data, we even have those who have managed and continue to refer to Mbarara, especially to ICU. So Kambuga will have those maternal deaths because it is the referral center for the district. That is one. Then, and if you go in our data, the only maternal deaths are those which have come from the community. Those came in actually dying on arrival. 2 of them from Bugonyambi, all those who went to the community and sensitized the communities on abortion issues. On the referrals, I'm not sure about the data that we're using, but just in May, we were reviewing our data actually with the State House team, and we found we only had 3 referrals out, and the rest were referrals in. We had about 54 referrals in. That was concerning data from December up to May. So I don't get it when we say we have a lot of referrals out. We had some referrals out around June because we had issues with anesthesia. The anesthetists, we only had 2 anesthetists and 1 had gone on leave. So now we could not stretch 1 anesthetist to work through all the time. So the times that we were referring out were the times when we could not now get another anesthetist. Much as in some instances we managed to engage the anesthetist who was redundant at Rugeo Health Center 4 to come and cover for some of the days. But most of the other days were not covered, and so those were referrals that we had. Otherwise, we are not having that many referrals from Kambuga. They are not there.
12 months retention. Next slide, because this is the one which will explain. I don't see my camera. This one. Next slide. The scene. We have those who arrived in ambulance, and that one, and the rest. That GCS, who can tell us what GCS is? Thank you, doctor, for that. I've also learned that. Is my presentation over? No, I expect. This one I had finished.
Yeah, you started with that one.
And this one we have 161 and we audited 157. And the institution of perinatal mortality, we had 12. Next slide. Morbidity, we have non-pneumonia as the leading cause of OPD. If you go back on the slide, people are interested in the slide.
Okay, next slide.
Next slide, we have individuals identified. We have Rukunjiri 4, which managed to have the yield, the rest are below, and the newly identified. Pardon? Previous slide, please. Previous slide. we managed to identify 4 leprosy cases, of which one of them was identified by Kigezi Hospital and 3 were identified at North Kigezi. We have more numbers than the rest. We also have motor vehicle, bicycle, and others. NCDs, NTD, neglected tropical diseases. We have those ones I can't pronounce, so next. Next slide. Those cases were identified in these facilities. The previous slide was giving us the district picture. So these are the facilities which identified those cases, whereby Kabale Hospital has most of the cases with the similarity 149.
Done a good job. Let's clap for her. But before you go, answer my question. What is your biggest challenge, your biggest gap? If you wanted the commissioner, the DG, listen.
To the national target.
And sometimes patients, all these mothers, are not willing because they had come to health center for a free service. Now we are sending them to Kigezi or Kabale, where they
to revise that. So they are 64, not 67. No, they are not functional. They are non functional in a way that reflects them. So they are non functional. Then the HMS reporting rates, we look at the quarterly reports, that is the TB section, HIV section, lab, monthly report sections, then inpatient also. Kabale is at 100% for everything, for less than 80%. But we are, as you can see, our previous weeks were all at 100% for Kabale District. That's for the weekly surveillance among the top 10. And for the last 3 years, actually,
Don't be surprised.
Kabale has been having no malaria in the top 10.
Among those introducing the
Yeah, it hasn't been in the top as the region as the top leading cause of death for premature baby, because we have the regional referral hospital and their data is part of that. Also the neonatal conditions, they are there, pneumonia and please, let's go. You're running. Okay. The next slide, malaria, 6.1% positivity rate. Then the next slide is about the ANC performance. For the ANC performance, we look at that. We have some facilities that are in red. We extracted hospitals and the center force to look at how they are doing as per the deliveries and variant sections. We look at Kakomo. Kakomo is a center that is not functioning. It has one theater, so it's where you see. We look at the Kabale District. Injuries. Those were the injuries per 100,000 population. They are still high perinatal death rate. So we are requesting maybe our DG, Kabale still has a challenge of perinatal death, high perinatal death. Maybe they can invest in midwives and doctors to help out. And then
he has forwarded that question to the commissioner.
Okay, thank you. Then the other challenge we have are HMS reporting tools. We are seeing this data, but really we are facing a very, very big challenge with the HMS tools. The tools we are using, registers, reporting tools, we don't have the tools. As we talk now in Kabale, we don't have OPD registers. We don't have any.
All districts don't have. Okay. What did you do?
The issue of prenatal death,
What's been done?
like we mentioned earlier, there's a lot of investment for the maternal death. And to be specific, with regard to EMS, the ambulances, the fuel we have is just little. That when a facility has a baby that needs, to be transported, the baby. So, Commissioner, we need more fuel such that even for the babies, the leaders can call and say, DH was in the ambulance and we're able to say,
Infrastructure for those babies also in the health center.
I'm being direct something specific that I need now. The Commissioner, I'll be following up on that.
That one is fine.
Recognizing the people who are with us online. We have Wakaba, we have Valencia Felix, somebody who is being with us. I want to give 1 minute to the DHOs of the presented, those whose biostats are presented, to answer my questions so that we can open it to the House for discussion.
Thank you very much, Chair.
Span of Kigezi, we are seeing a lot of prenatal deaths. For Kogeri in particular, I think we need some ample investment into both infrastructure and maybe capacity building towards the management of what? Of these neonates and so on. Because Rukungiri is so peculiar that if you are in Rukungiri, where do you decide to reform? Do you go to Kabale or you go to Mbarara if you wanted specialized services? You have to go to Kabale. Now then, the issue that my brother has raised is fuel there. Sometimes you find you have to refer a mother and then a mother will say, I might not go to Nyachibare if I can't go there. Nyachibare, which has tried to put some form of like an ECU, it's still in its, it's not well established. I've already raised that concern to the commission that we need some form of investment in how we can manage the neonates and so on. But my staffing is at 28%. So in most of the areas, you will find one person. Health center tools actually have one person because the nursing assistant who is still attached there, ideally their position was what? Was critical. So we need some pragmatic steps to be taken as far as getting us somewhere human resources concerned. The other concern that
This is to do with infrastructure and training. Because if you find the whole regional referral hospital having about 4 or 5, 6, and this is a population of about 6 million people, I think there we need to do more. But I want to take another angle.
Kabale. Oh, yes, Kabale, you want to fine-tune it.
In the age range of 15 to 29 there, especially females, that's becoming a big problem. And then
New infection.
Yeah, infections. And then support to health promotion and disease prevention, especially for community mobilization like the DHO for Kanungu has said. We are very thin on the ground. We are not engaging the communities. Like the VHTs are hardly engaged unless we have like some campaign or something. So we should be able to be seen in the communities. And I think that's why like for Kabale, we are struggling with the first trimester ANC. We are very few are coming. They come later. But if we are very active at the community level and having radio talk shows, maybe we'll be seeing the community responding fast or early enough. Capacity building and also related infrastructure and supplies. Reporting, like DG and the commission as we speak, both the hard copy tools and the soft, even the DHIS2 is off. Actually, that one is, I don't know what happened. For the last month, anytime I ask my biostat anything, system down. You saw some of our data elements were missing. Why? System is down. So even there are things that are happening that we may not be able to even analyze because the systems are down. So the reporting is key. Thank you very much, Chair.
So presentations from the 3 districts, the double case and 1R. So, to refresh in your memory, Kanungu, what I can put across is that we have 2 non-functional health center force. Yes. They are vaccination rate, new vaccines at 38%. That's Kanungu. They will give us the details. And the Commissioner, what is key? If you look at the emergency medical services, the percentage of patients being ferried in our ambulance is around 5%. The one who presented the general picture for the region says we have 37 what? Ambulances in the whole region. But only 5% are able to access the ambulances. Where is the problem? What is the denominator there? The emergency, like for example in
referrals in or what is the denominator? It should not be
in or out.
Okay.
Yes. For example, I think Munjiri had 73 out of 73 accessing ambulance out of 1,437, I think. There is a challenge there. The challenge I can see is probably coordination. Is it already around?
Could be the denominator.
Okay.
Huh?
So
those in need, only 5%
are accessing the ambulance. So what is the problem there? The other key issue that has come up clearly is the prenatal deaths, and we're not going back to it. And then there's another thing, PNFPs and private health facilities which conduct immunization, but they are not accessing what? PHC. Actually, we found it was also a challenge. We allocate every health facility some catchment, including those which do not get PHC. So can we call for questions? You ask specific question to a specific district. If you have a solution, also put it across. And we are giving ourselves only 15 minutes to respond to this, and we expire our term of sitting here. I see, let's begin with the director here.
Thank you. The MS. A very weight in the district was contributed from there, and yet at the same time, it's also the facility on our record that has a very high number of referral out of mothers. I seems not to be able to connect the two. What is happening inside there? Third one is to the DG. We are having mothers walk to hospitals, ambulances packed. Reason? Fuel, I think we give 2 million, something? 2 million shillings? If you're going to Mbarara, 2 million shillings, I don't know how many Akasima does. But that is challenging. For us in Kabale, well, I need to go to Kampala twice, and it is done. And sometimes we have to go to Mbale. Do we have any plan? Yeah. So do we have plan of increasing this? If we don't increase it, then our people will continue to have to fuel the ambulances to take them to where they're supposed to go. And imagine you are paraplegic and you're looking for 1 million shillings. Terrible. Thank you.
It's about the referrals, the eligible vis-a-vis, of course, accessing the ambulances. My response would be on 2 areas. Number one, how do we track this indicator to begin with? Because I was here meditating upon the credibility of the actuality, of course, of the information provided here. 73 out of 1,000, when actually I've witnessed that the biggest number actually is carried by our ambulances to begin with. Number 2 reasoning would be that the fuel we are given is actually not enough, just like the director states it. So if the fuel is lifted up, glory to God, we shall have good news as far as accessing these ambulances is actually concerned. But importantly, we must also define the parameters under which we assess this indicator. Because I imagine if I sent maybe from Buhunga Health Center for a mother to probably Nyachibare Hospital and they go with the ambulance, when they get to Nyachibare, where do they record the fact that actually this mother whom I referred there probably came with the ambulance? Or if at all I referred them to Kabale, I actually wonder whether there is a method to track actually this referral vis-a-vis the means of transport that brought it there. So it should be informed very well in order to have a clear discussion by the Office of the Prime Minister. Whenever they come to us, I've already seen them look out for increase in numbers, like for example, OPD attendance. And the subject question I have is, if at all we take it up from what the DG advises, that it is our honor and responsibility to close the taps. If we close the taps and there is no more leakage, for example, then what would be the interest? Is it to increase OPD numbers or to actually reduce? Because if we did prevention very well and health promotion, why would we want to look at OPD numbers increase? You see, I sometimes want to reason these things. Maybe I'm overthinking probably, but I could be guided at the end of it all. Same comes to antenatals. You're saying do a lot of family planning at the same time, and then when you come in, you're actually looking for increased antenatal care, increased deliveries at the end of the day. So what do we take? But anyway, that is logic. Probably that is okay. But when it comes to OPD attendance increase vis-a-vis versus, of course, closing the taps, there is a subject question there. I thank you. Thank you, Chair, for the opportunity.
Jude Collins Musinja, Kabale Regional Referral Hospital. I have two questions. The first question is directed to Kanungu District presentation. I saw in the slide a spike in leishmaniasis, and I picked interest. Leishmaniasis is caused by Leishmania species of particular interest, Leishmania donovani and Leishmania tropica. And they are spread by the sand flies, the phlebotomy. So my question is, I'm seeing that spike in, I think, Nyachibare Hospital, 149. So I'm interested in our epidemiologists in digging deeper if our region now has got sand flies, so that we can be sure that we are dealing with leishmania, because it is a disease that is common in eastern Uganda, Karamoja region, and Kenya, the Turkana region. So are we having a situation of emerging or re-emerging tropical diseases in our region that used not to be there? The second question is for Kanungu and Rukunjiri. I'm glad Kabale District presented aspects of diagnostics. It showed an aspect of lab. Does it mean Rukunjiri and Kanungu you don't have labs? Oh, the labs are not important for Kanungu and Rukunjiri. I've not heard something that relates to lab. So why are we here as DRFPs, as regional lab managers, if we cannot hear aspects that relate to lab? Thank you.
Thank you, Chair. Protocol observed. We have seen that perinatal death is very common in Greater Kigezi. And when we look at immunization coverage, the performance is very low. So we don't meet the target. How do you expect to prevent perinatal death when the immunization coverage, we don't meet the target? I don't know the DHOs and the whole of Maternal and Child Health Commissioner how is going to help us to improve immunization coverage and antenatal. Secondly, Rukunjiri has reported leprosy, 2 cases of leprosy in Rukunjiri. What step? 4. What step have you taken to prevent further infection? And how have you managed these cases? Have you informed our epidemiologists that we should identify? Hello? Thank you, sir. I had mentioned the issue of perinatal death. I've said Rukunjiri has reported 4 cases of leprosy. Have you bothered to talk to our epidemiologist, the regional epidemiologist, to make some survey and prevent further spread of the disease, even identifying those cases and get managed in the special clinic in Kampala? That one, I think it is captured. Kanungu District mentioned that they are doing household sanitation, something of the kind. Have you bothered to work with the VHTs and do home visiting, even using LC chairmen to distribute mosquito nets so that we prevent malaria and minimize perinatal death and maternal death? I submit, Chair.
I think it is because it is bundled with hydrocele, and hydrocele is a common condition, especially in older adult men, and I think that is where the problem is coming from for filariasis. But I had the same concerns about leprosy and leishmaniasis. The other thing is about prematurity. In the regional performance, we presented prematurity causing about 177, and when we broke it down per district, Kabale has 79, which is about half of the death, of the perinatal death due to prematurity. And I think Kabale, we have a bigger problem probably. Maybe because that is where the only public hospital in the region is. But I have been thinking through this prematurity. Once you have had a premature delivery, you have a high risk of getting another premature delivery, meaning this problem has come and it is with us. And so what do we do? One is the counseling that we give to this regarding the next care for the next pregnancy. Treatments you can give, for example,
and so that means Rugarama Hospital is the leading place to actually offer neonatal care. But right now, because of the cost of caffeine citrate, we cannot admit a patient. Because caffeine for 1 week will accumulate a bill of about 1 million. Because caffeine citrate is 35,000 on the market. So I don't know how the ministry can help us to source caffeine citrate at an affordable price. And maybe working in hand with what my colleague has said, we see how to provide this to neonates and prematures at that subsidized cost. Because we are losing them in big numbers because of that cost of some of those essential drugs. Just to add to that, we have Emotive, and I think we have rolled out very many other bundles for maternal health, but we haven't had much about bundles for prematurity, bundles for asphyxiated babies, bundles for prematures on how to refer them. So hopefully our commissioner who is here will look into that and we begin to see how to roll out care packages for these prematures and these sometimes asphyxiated babies that are being referred from tertiary facilities, from the lower level facilities. It hurts some of us when a baby comes and they die when you know you could have done something before they came. I know we haven't reported much on NCDs, and yet I know they are on the rise. They have become a challenge that is here with us. And still again, Rugarama Hospital is the only facility offering dialysis in Kigezi. I don't know if the referral is about to start, but Rugarama is the only facility that offers dialysis. We don't have much help. That the Mtebele Foundation is funding us with consumables, but that is not enough. Over the last 8 months, I have had more than 10 clients who have walked away from care because they can't afford. And yet we are offering the service at the least possible cost that we can. We are offering it at 150,000 because the Mtebele Foundation is giving us consumables. That is per session. But many of the clients cannot afford that 300,000 for a week. 150 for each session, and they do 2 sessions a week. So how can the ministry come in to help these clients subsidize? Because kidney failure is on the rise. We are doing our best to fight the battle. We are screening, and I know that's a district-wide effort.
but we know we are identifying more and more, and we are also receiving AKIs who are coming in. How can the ministry step in to subsidize for us as we wait for the referral to actually start up and take on more of those clients? Thank you very much.
Questions? But members, I told you that we are here to generate. He's even the custodian of the solution. But why stop at the question? I asked about the issues, maternal death, late referrals, and a few other challenges from Kanungu Hospital. The MS is here. Take the stand and answer the questions.
Is it part of the hotel service?
Concerned?
No, overall, you are managing. You are the MS.
Yes.
Managing your staff.
Yes.
There are no performance management issues.
No, we don't.
Okay, I hope that we shall take his answer, but let us try to be as realistic as possible.
Yes,
this
is Kanungu referring out, but
yeah, that's it. You can't have 3 referrals out only in a period of 6 months or so. It's not possible, realistically.
It's on the lower side, yeah.
It's on the lower side. I mean, some things we just need to be realistic and
a hospital level really, which has 2 gynecologists. The cases that you refer out most mainly will be these cases like acute kidney injury.
Really realistic in referral out. That's why I said there's no reason. That's why I would say let's number it to have many. Yes.
Every referral from the hospital, be it medical, be it surgical, be it gynecological. So 3 is meaning that you are actually working on every patient satisfactorily, which is almost next to impossible. But I agree that it's a referral site, and probably we need to put more energy in trying to make sure that the referrals that come in are attended to in time. How to cross to narrow that 7 mothers is a little bit on the higher side.
Which only 2 are hospitals. The rest have something which is similar to a lab in terms of infrastructure. And what they can do, most of the things they do are these rapid tests, malaria, HIV, and all those. And that's why in a different they were reporting about them. But if we are looking at the chemistries, how much of full hemograms we are doing, most of our facilities don't do them. So that is an area where we need your support and the director to get us more of the infrastructure and the equipment so that we can have robust laboratories in our centers. Secondly, we want to request through the director that we need to make yourself available and support us more on these things, because some of our lab people might even be forgetting microbiology and other things, because where they have been positioned, they don't have the capacity to do these things. Then on the cases of leprosy, sister, true, there are cases of leprosy in Uganda. Don't think leprosy ended with when Jesus healed the 10 lepers, no. Leprosy is there, only that its incidence and prevalence came down. We were partaken, I think about 2 years ago, we were part of the team that was developing the national, is it eliminate leprosy by 2030? And how did we come to do this? When those cases were discovered, we brought on board our DTLS, our TB leprosy focal person, and the regional leprosy focal person. These patients, we got the drugs for them, and even there are some of those special wear, terms of shoes and so on, that we had to get from the ministry too, so that we minimize the likelihood of disability. So as far as care is concerned, care was given to these persons. Teddy during our break, Teddy can give you the follow-up reports that happened. What did we do? Of course, for any of these cases, contact tracing had to be what? To be done adequately. Thank you very much. Then discussion on EMS. I want to re-echo my concern. I think this indicator that you are trying to bring is that you are trying to look at the performance of the Regional Emergency Operations Center, because a lot of data is missing here. I can vividly say my health center falls when they have issues, they use the ambulances to pick mothers from center cities and manage them. Unless if those ones are not referrals, but they are not being captured anyway. Like has been said, as we look at it tomorrow, let's look at how are we capturing this data. If I pick a mother from health center city and take her to a health center fund, she's managing. Isn't that a referral? Or we are only looking at referrals where people have made a call to the Regional Emergency Operations Center. That with other questions about Rugunjiri during the coffee break or thereafter.
Use of oxygen, especially in PDFPs, but you include it on their bills for patients. How? Go to DHO Kanungu as they think about the question. The PDFP.
Based on what I think could have been a misdiagnosis concerning leishmaniasis and filariasis, I asked my district lab focal person about causing staining her, diagnosing or using rapid testing. How did we come to have those diagnoses? Because Kanungu also has. So I think our knocked out 3 stars, probably. Kandi ekindi ekikoliga yagambireho for filariasis, I think to say hydrocele, stroke, filariasis has been confusing. So again, that is something. Now, for me, ekindi kwenda kubuza hano ya nokushaba commission for reproductive health. Do we have?
Excuse
do
me,
we have,
DHO.
yes?
Have you finished on the issue of leishmania?
Yes, I have stated it. I'm
Okay.
just saying I'm rejecting that.
Okay, now
Because
let
it's
me.
a misdiagnosis. And what I wanted to add is regarding contraception promotion and request that we have regional specific targets. How many, what should be the minimum number of children per woman, you know, we should be targeting. Because if we are not cognizant of that, we shall also be now reaching a point of incentivizing women to have children. Do we have it? Yes, let's be, because I've been looking at different regions. In Kigezi, the fertility rate is coming down. How many children do we have to have per woman to maintain our labor workforce intact? Otherwise, we shall be regressing. Twin technology, that's one thing. We shall regress. This is a fact.
I want to suspend any further discussion on leishmaniasis and those other neglected tropical diseases. And I will therefore ask I will ask the team, the data team, because there seems to be a data issue generally about that. So I'll ask Dixon and Henry to first understand whether actually those cases are real or it could be just an error. The DHO has disowned it.
It's not attached to any facility, then it becomes a regional issue. But if it's reported under your health facility, it is your team to investigate it. You have a district surveillance focal person.
Those cases are not there.
But you see, excuse me. By the way, a data capture issue could have been missed because, as we told you, we have been having a long downtime as far as DHIS functionality is concerned. So some of these could have been some of those emissions that came on board when the DHIS2 system was not well functioning. That's why we say we need to go and verify. Okay? We are not saying this is not being reported from the district. We want to verify really. Because this is an issue that needs attention of everyone.
And
like
that's
the
why
way it caught each one's eye during the presentation. Okay, thank you very much.
And that's why I suspended the further discussion on that. But allow me to ladies and gentlemen, to make you aware that we have the RDC of Kanungu in our presence. And to officially open our engagement here, but we are aware he was in a security meeting, but finally he's here, and we welcome you, Bwana RDC, and at some point we shall ask you to come in and give your remarks and open much as it has been, reopen much as you found us discussing, and also assure us that this team is safe in your hands tonight. The responses. So issue of data, I think Dixon and Henry kindly look into it. The issue of prematures, those incubators and dialysis being at PNFP Rugarama, thank you for letting us aware. But to the standard of Regional Referral Hospital, it is supposed to have those units. The Regional Referral Hospital Kabale is supposed to have all those functions. So, what went wrong or what's not happening? I think the director can give us a clue, then he can push it ahead, or probably give us Atumaramas.
Going to have me dehydrated here, but nonetheless, we're here to talk. Dialysis. We are having our intensive care unit constructed, and on the ground floor we shall be having dialysis. It is over delayed. We sometimes don't understand why, and hopefully in the next 2-3 months we will be able to dialyze. As put by Rugarama, it may not be able to be provided free. The consumables are expensive, and so far we do not have money coming with it to employ the people required there, to buy the consumables, to provide for the utilities and cleaning security. We are going to ask our big people when they come to launch to give us those resources. Support to laboratory, this is overdue. I can only say my team need to wake up, and the head of lab is here. You only need to give them a bit of time to come there. There is some small money they are given that should be able to allow them to reach. And the matters of Kanungu is an emergency almost, because we don't want to see all the Ministry of Health here, because there's leishmaniasis and I don't know what else. Because it will appear there and it will be picked up. When I was in Arua, somebody reported a terrible disease, and we saw WHO, Minister of Health, everybody, and they were like, what's happening? He said, oh, you said you have it. Yeah, so it was serious. We don't want to do that. Leprosy treatment is at home. I think it is okay. We don't need to be worried. Our problem is the doctor's ability to pick leprosy is wanting, and the TB leprosy zonal team need to invest in that. And so it is in detecting TB in children. Those two things, we need to relearn them. We say it is not there, but in West Nile there is a huge number. Maybe because people have forgotten how to identify them. I think it might be updated also. It states the date and where it is coming from. It allows even a SCARE to sign. It doesn't tell us the time at which the patient was referred. I think for maternal child health, this is a huge parameter that we cannot ignore. We need to look at that form to capture. And then there are also issues. The other day I got instructions from the Minister of Health to go and pick a patient from Kebisoni and take to Kabale. So I switched off my phone and dived into Bunyonyi so that I could not be traced easily. Finally, even him can catch me on that one. Finally is oxygen. We now have 3 oxygen plants at Kabale. It is distressing us a lot, but the assurance is anybody wants oxygen in the region, we can supply. For PNFP and for government public facilities, you pay no money. Just write a small note to my administrator, bring your cylinders in time, we'll fill it and take. But ministry, my power consumption is 4 times what I used to have. Since you represent our big man, Matia, we shall take that. Thank you very much.
Somebody talked about lab data not being reflected. Yes, Kabale, we did something. I wish you can bring that side back and I say what I want to say. Kabale. Okay. Yes. As we were discussing, somebody said that we need to open the taps. Yes, when we come to laboratory testimonial implementation at our centers, especially particularly Kabale, we are not doing well. Yes, because at the Center 4, we are supposed to have chemistry tests done, LFTs, RFTs. But unfortunately, in the whole of Kabale District health centers, we do not have any chemistry machine. Okay? So we all refer samples or clients to Kabale Regional Referral Hospital, where we know the big man is saying that he does not have human resource. So it is a challenge to us, and we wish as Kabale District to be helped since we have the DG here.
That is understood?
Yes, please.
Those basically
HMI stools, and me as the person who is who heads data in my districts, I'm very much worried that next time when we appear here, we are going to be having worse data because the system was changed. We don't have the HMI tools, the registers, one commissioner. The registers are not anywhere in these facilities. So I expect you to update us how far you have gone to ensure that your facilities have the tracking registers. Thank you. Then my other issue is about the stability of the system. Please take it up because it is compromising data entry at all levels. Over. Thank you.
Thank you.
3 drugs are emerging as very important. Number 1, caffeine citrate. Number 2, anti-D immunoglobulin. Number 3, vitamin A. So, from the presentation, it has emerged that most babies die as prematures. I have a child who was born as a premature. He did not die. So, the presentation seemed not to explain to us what exactly kills these premature babies. Is it because of breathing? Is it because of lack of warmth? Do they die because of coldness? Etc. So, caffeine citrate, for example, helps the babies to breathe well when their lungs are not yet developed. So the question is, are these the people ordering for medicines in these other facilities? Do you have caffeine citrate on your order forms? Is it there? Is it at your level of care? Number 2, anti-D immunoglobulin. Because I've been receiving orders from some of the districts asking me to provide for them anti-D immunoglobulin. I cannot really quantify to be able to redistribute the anti-D immunoglobulin because I cannot estimate how much you'll be able to need. So the question is it possible for the regions also is it possible for the district health centers to be able to order for their anti-D immunoglobulin so that they don't keep on bothering the regional referral hospital? So the other question is to the bosses. The question is, even when we have these 3 drugs on our national medical stores order list, right now the delivery came without these important items. There is no caffeine citrate and there is no anti-D immunoglobulin. So how are we going to prevent the death of these premature babies? Thank you.
The national picture looks more or less the same, but probably it's much more here in Kigezi. So we are aware. And just last week, I was telling, I think, DHO Kabale, just last week, I presented this issue to the National Planning Authority. and then we've scheduled it to be presented before cabinet, the high numbers of neonatal mortality in Uganda. So that's one stream that's likely to get us money to fix all the resource gaps. It has been attended to at the highest level. It's not even now a Ministry of Health issue. It's now an issue of the National Planning Authority, neonatal mortality. Isn't that one good? Yeah. Now, another exciting news is that I have a project coming next year. I'm beginning the planning this year. This is now money. Kabale will be part of that. Kigezi. But I want you to do me a favor. There are things that you are not discussing here. The issues of the non-functional health center FOS. Kigezi is the only region in Uganda with the highest number of non-functional health center FOS. Busanza, my cow is here. I wrote them, I sent them to PS this morning because I was actually briefing her that this region has the highest number of non-functional health center FOS. Rujeyo, and Impungu. And what is annoying and what you are not discussing in the front of the cows is that you've posted doctors in non-functional health center FOS. Who has posted doctors in non-functional health center FOS? Because these are the issues you should discuss. Get them where they can work. Someone has just mentioned from Kanungu that they are picking an anesthesia from a facility that is non-functional to come and back up. No, these are irregularities. There's an officer who has studied anesthesia in a health center for called Rujeyo that is non-functional. But you know, Busanza, everything is complete. I hope we can functionalize it before October. We must move with strict guidelines, strict deadlines. And the Bachika are known for having that energy and strict. For Kakoma, I know we are going to move. For Busanza, we begin the preparations. The problem is the DHO. He's never in these meetings. And you don't talk about it. As a regional forum, including Dr. Nyeko J, the DHO of Kisoro, is never available. I'm happy my sister, the DHO is around. But your DHO is never available. He attends when you want. It's not an issue of attending when you want. All these guys have left their offices. They are here. It's not an issue of attending when you want. But we don't talk about this. When the whole director of the health system in Kisoro is not available. If that becomes an issue, then we see how we can help. So, neonatal mortality, on another good note, we are training neonatologists. I did not see anyone apply from Kigezi. I could have picked anyone from Kigezi. And for you to be a neonatologist, you need to have been a pediatrician. Yeah? No, anyway, even these PNFPs, if I see anyone, I sit on the committee that's awarding these scholarships. If I see anyone, a pediatrician from any of your hospitals applying for a scholarship, if they are not finished, next year they are coming. Now, you should not say to Turabagambi, next year I want to see someone from Kigezi applying for a neonatology fellowship, fully paid. She has to apply. Why did you express interest? Just completed. Anyway, it will need approval of your system, whoever is the accounting officer, to say this is the person. We want people with interest, we want people with passion for these newborns. The moment we build those capabilities, equipment is coming, that's one a guarantee. And we are going to build, support the health center force that Dr. Kasim has been talking about, with newborn care units level 2A. Level 2A, they have CPAPs. Actually, my biggest role now, what gives me headache is how to mobilize resources to fix such gaps. And I'm seeing resources coming, and I've confirmed that Kigezi will be a priority. So any issue on neonatal, we stop it at that. We are going to implement. We also have an in-service training now. Before October, we are going to train 180 in-service nurses. How to manage these newborns. 1 month intensive course on it, fully paid. So if you don't send us your people, then you will be left behind. So I finished neonatal. Busanza, we must work. The cows here, get us the workers. I'm even following up your issue. Good luck, the PS allowed. I came with some answers. The PS allowed your request cow. Don't ask me what the request was. And then this man of Muko man, we have given you your anesthetic machine. He sent me a message this morning. That guy, I think we clap for him. He's very hardworking. He's a very hardworking in charge, Muko, and yeah. So those two have been fixed. Gross understaffing at district. This was Dr. Kasim. 28% of the new structure.
But even the old one, I'm like.
Now, the new structure, don't stress yourself so much. Even us at the ministry, the target is to fill the new structure to 55% by 2030. Can I repeat it? To fill the new structure to 55% by 2030. Can you use that target?
What should we be at least with the old one?
We are moving with the new one.
Yeah, we are stressed, you man.
No, this is not. We are communicating a position of government. That the government's plan is to fill the new structure to 55% by 2030. Today is 2025. You move from 28% and reach 55% by 2030, you would have done 100% of your target. So the issue of denominators, who you put is your issue. What informs this is how money comes in from government. The money is not coming from Ministry of Health. When the Ministry of Health had a dialogue with the President, we were informed that we need to stagger this. First of all, he had even wanted to refuse the whole new structure. But he said we can implement it in a phased approach. And that phased approach, by 2030, 55%. So if you're already in 40, you're doing so well. I know what you're meaning. It's really hard. It's really hard to deliver services. But Onesimus mentioned something that I felt we could look at very critically. It is called optimization. He's trying to introduce something, though he introduced it badly. So he's saying that if you have equipment and you put it in his hospital, I've forgotten, Bugarama. If you have equipment, instead of dumping them in Rukunjiri 4, where there is nothing going on, like an NGO, nothing going on, why don't you put it in Ugarama so that these people, we have an arrangement. The Ugarama subsidizes. There is an arrangement. I think there is an idea there. We have so many health centers we have been moving around. You find equipment is just hip. And then the PNFP is there and we are not utilizing. So I think he has an idea, but it's worth exploring. Incomplete and called community hospitals. I think now that's a common position. All health center for community hospital is not equal to general hospital. They are not the same. A community hospital has an expanded service package and human resource. For example, from 48 health workers were at the health center 4. So we times 3. I was told that we use a factor of 3, 10, 3. So 144. Thereabout. So there are 5 doctors instead of 2. This is an increased service package. And I'm happy some of your districts, I keep getting information are about to begin implementing those structures. So the human resource issue is going to be a challenge with us for some time, but there's also good news. Cabinet passed a supplementary budget of around 40 billion in 2 weeks, 2 weeks ago. And this money is going to support to bridge the gap in human resource for the USID because of the US gaps left behind. Immediately that money comes, it was passed because I was in one of the meetings, and that money will be for recruitment. But it might not, it's not a lot of money. For recruitment, it's not a lot because our salaries are a bit heavy. So the priority was given to higher cadres, I think doctors and above. And the rationale was to create an environment where interns, because we're also trying to address 2 problems, the problem of interns and the problems of the human resource gaps. Because interns at general hospitals should be supervising. And I wish before this meeting ends, we could have a general just outlook, maybe 10 minutes on how interns, because Kambuga should be having, if you have specialists, do you have DH? Kambuga, you have? Very good. At least most of the general hospitals now should be having interns. There's a way they help. They are better than nothing. So I think that is good. I return to. Now, for the choose, the money, it's a very good strategy, well embedded in the community health strategy. But again, when we are discussing, I had my friend, the DHO of Kanungu, saying, we go operationalize a community health strategy. You know, such a statement is not very committing. As Dr. Abdon, if we come back next year and review the same statements, there must be energy and action towards what we are saying. What exactly in this are we going to do? What are we committing to go and do? Like I've come here to tell you, I'm going to train your nurses in service. So you'll come back here to mention how many have I trained. If it is an issue of having health assistants or recruiting health assistants or facilitating them to work, to do outreaches, we come back here and count. One biggest disadvantage we have is that the laxity, the redundancy, the money we had of Lawrence, my friend Mogomia, that we had 1 year ago is no more. It may come back, it may never come back. This is the first meeting that we are holding without money of our funders. And we must all live here with the realities that we are living with. If we don't do promotion and prevention, the hospitals will be overwhelmed, the drugs will not be available, leishmaniasis will come back, Dr. Kusima will come and tell us it's a data issue, it's a data issue. We shall discuss at coffee time. So, we want to go out here with the conviction that as leaders, as people selected to manage the health system, we need to do more promotion and prevention. If I don't know if we got another, the people we borrowed money, we used it during Ebola, we've never paid them. Some people who were wherever, the health workers, I hope this side did not have Ebola, but we've never paid them. The money is not available. Now that even comes to the issue of fuel, and which I'm going to end with. Now, choose the program right now is supported predominantly 100% by partners. It's very unfortunate. I'm going to inquire why Kigezi has not received even a single district, because Rukunjile, I think they launched yesterday.
Yeah, no. We are now training. 200.
Yeah, at least. No, at least don't complain. 2 out of 6, because now we are on district number 23. We are on district number 23. For you, out of 23, you have 2. So the rest of Uganda has 21. Rwenzori that has 10 districts has only 2. Change Joe, yesterday I launched in Winyanga. So this one choose as money gets available, we take in more. We appreciate that it's very transformative and it strengthens our community health system. Of course, the districts that already have choose or where you're implementing, and don't politicize it. It's not a political issue. It is entirely, it can be very serious. Don't politicize the issue between the choose and VHTs. We need all of them. VHTs at village, choose at parish. So I think that one I have finished. The more the money you have your advocates, Dr. Mutunji is here, we shall keep advocating so that we cover. And for you being 6, it's easier to cover all of you. And lastly, on fuel. I've always made my case and I've advised. I worked at the health center where my mentor left me. I have worked at a district. I know. I have always made my case. And on the DHL's forum, that man, my friend of mine who thinks abstract, he confused you. The best solution, and I've just sent a message to the commissioner ambulances there in Masaka now with the PS. How is the issue of fuel? It is very painful for a mother to die, for a patient to die, and we are telling them there is no fuel, especially for emergencies that are not giving us time. I've always given my advice, and PS has bought into this, that the health facilities pool fuel. You get a common pool. Rwenzori has adopted this as one of the resolutions for the GRM. The Rwenzori GRM, every district is going to pool fuel. 200,000 for health center 2, 300 for health center 3, 400 for health center 4. By the time the fuel of Ministry of Health comes, I asked the transport manager, where is the fuel for Kigezi ambulances? He said, we sent a supplementary finance, it has not come back. What does that mean? He has said Yes, we sent the supplementary finance, they have not responded. I cannot put a timeline on when you're going to get fuel. I cannot. The transport officer just told me now. So, should we park all the ambulances? The answer is no. Why can't every health facility, like it has been done, Ibusoga has done it, Westnell has done it, Wenzori JRM has resolved? It's not an audit issue. It cannot. The cow is here. This money at facility level, the highest, the decision-making body for allocating the money is the health unit management.
Yeah, but Commissioner, this is that I was in another position actually during RBF, during AMCHIP, and the guideline that planning was giving to health facilities is that health facilities allocating, contributing to a central pool of money is against the public finance management rules and guidelines. So it has to be dealt with at a certain level.
Fuel, not money. Let me tell you how it's done. I call it the. I had seen this. I had predicted this. It is very difficult to manage things from memory. It will come after 6 months, and you'll park them. So I told the Kamuli team, and we worked out an experiment. Contribute. The in-charge does not bring money anywhere. He takes the fuel to a petrol station and picks a receipt, so that collective fuel is managed by the ADHO or someone chosen by the DHO. Kamuli has more than 5 million on their account for fuel. You don't create a cost center. So in their budget, they pass a budget for emergency fuel. Every facility contributes to that. That money might not also be enough, but Kamuli is not complaining. If any of your DHOs can ask Kamuli, and I don't think for any in-charge who is here, that money is a lot for 3 months.
They take receipts. Clarify, please.
No. If you're in charge of a health center 3, the quarter the money comes, you get 300,000, take it to Total. We are all putting our fuel at Total. All you need as evidence that you've paid your money is a receipt, and that's what you use for accountability. Think about it, guys. But if you also have a problem, ask the guys in Kamuli, ask the guys in Rwenzori. Every district in Rwenzori is implementing the same. But so that when the other fuel comes in, it comes in as top-up. The time now requires us to have local solutions. I liked Onesimus. He tried to create an environment of creating answers. Even at the ministry, we don't have the answers. They are not there. You will sit with Diana and say the answers. No, the issue of labs, this is the last one. Unfortunately, I tend to attend in most functional. The labs, what we are using is called a placement method. We don't buy equipment. So if there's any lab health center for in Kigezi that does not have a CBC machine, please let me know. I will inform the commissioner. I want to begin with CBC machine. Even in chemistry, by the way, even chemistry. Now, the biggest challenge, because I was talking with Susan before I came here. Susan is the commissioner for laboratories. The biggest problem now is reagents. The reagents were supported by Mozungu, the money for reagents. So we are likely to buy a little reagents, but the money is not enough to buy all the reagents. So we can even have white elephants. Equipment is not the problem. If you need equipment, let me know. The problem is money now for reagents. Labman, have you heard? Where is he? The problem is not equipment. So we are scared giving you equipment without reagents. Because the gentleman who places the equipment, for him, he makes his money in reagents. He wants us to buy reagents. That's the placement method. We can give all of you equipment, chemistry. We can give you CBC. We can give you. And even yesterday, there was those who attended MPDSR. There was equipment delivered in Abratuk. They lost their mother because, but the problem is reagents now. We are trying to engage. The commissioner mentioned that we are trying to engage now government to see if they can get us the reagents. And it's because it's money now. It's about money. But you remember, we are pushing on everything. Give us human resource, give us equipment, give us even ARVs and antimalarials. The donor is pulling out. So the landscape is not good. Chirunji si chirunji. So I think I've given Fortunately, I wanted to call
I wanted to make a call and see if I could get the answer. The first batch of caffeine citrate was free. We supply. Now I wanted to find out if we still have the free caffeine citrate. In my view, caffeine citrate shouldn't have been an issue because we had too much. So I want to know where did the too much go. But again, the biggest problem we have, and I think we need to investigate it with my team, we are having 200,000 preterm deliveries. This number has been increasing progressively, and we have not been able, but we have a lot of scientists here. Please investigate why are we having too many preterm deliveries. A preterm delivery is very expensive. On top of it requiring caffeine citrate, because they could actually require surfactant. A dose of surfactant is 1 million. We were talking about caffeine citrate, 35,000. Surfactant is 1 million. So we've been able to buy some few doses of surfactant. Actually, we have surfactant. If you have people who can administer, we can give you surfactant. We can put you on the list. Someone gave us a donation of surfactant. Free of charge. But even caffeine we must be having. We can give you free of charge. You are treating Ugandans. We can give you. So some of those rare commodities we can actually give you. And me, I have no problem with even supporting with other commodities. So caffeine citrate, I don't have a definitive answer. As far as I know, we had enough. And I need to double check with National Medical Stores and also Anti-D. Anti-D, because the problem is that some of these issues, I don't know why the chair, they come up when we are here. We would have come with answers. Me coming here to brainstorm is also not fair. I wish you had told us and we came with answers. But tomorrow I'll be around early morning, I think, the first session. Then I should be able to have answers for those ones. Because with residence incompatibility, our high-risk mothers are sent to referral sites. So it's very likely the districts may be.
I think recently, most of our labs were supplied things we had not expected.
Malaria. Huh? How come I eliminated malaria? We save money. Huh? No, if we can all say we eliminate malaria or something, they reduce, then we shall save money. The easiest prediction now is how do we work within what we have. That makes sense. It's easy to debate, it's easy to say, I'm saving here, I want my money here. The biggest problem for our labs now is not the equipment, it is the reagents. Thank you.
Do. Patients can contribute. We have patient groups in some districts. Patients with chronic illnesses, diabetes, hypertension, have formed groups, and every time they meet, they contribute something. 10,000, 5,000, depending on the capacity of the region. When the drugs are out of stock, instead of waiting to come with the kidney failure for dialysis or stroke, they buy their drugs. Those are local solutions. And some of those clubs have been registered with CDO. So even now during the campaign time, they tap into the politicians who contribute something in their pocket. Local solutions. Yeah. We have not come with solutions, ladies and gentlemen. We have come actually to listen and learn from you and take some of these solutions elsewhere, the way we are telling you about contributing for fuel for ambulances, about patients' clubs contributing something for themselves, about some who have enacted, are they called bylaws or what? Local bylaws so that you don't drink anytime or what? So we have come to listen to you more than providing solutions. Thank you very much.
I've been told we have to break off and go and look for where to stay, which is.
I'm very happy that we as health service delivery providers are committed to an extent of this level of collaboration and looking forward to how best we can identify solutions to healthcare problems. It is common knowledge that for any human being on earth to be secure, they must be healthy. And definitely we know that as government, we pay keen attention to all the security concerns of the citizens of this country. But me and you, greatly appreciate that human health is the first line of human security. When we're recruiting army officers these days, when the military is professionalized, the medical tests that recruits go through have a lot to do with how they were raised. Actually, from the time they were conceived in the mother's womb, how they were taken care of as babies, up to the time they go to look for an opportunity to serve this country as military officers. Should one be found to be having any slightest deficiency, they are disqualified, even if they qualify in all other aspects of life. Now, this collaboration is so towards this cause. Meeting together in this forum and sharing best practices is key in enhancing the performance of everybody within the sector. And we are definitely able to see the results in the way our people access healthcare. It is key for us to ensure that all Ugandans access timely, affordable, and quality healthcare services. And the best way to achieve this is when the key players take it up on themselves as a calling, just like I've really observed in this discussion, in the discussions. I was very impressed. Everyone is giving an idea. I like the idea of the commissioner and the director general that we must have locally generated solutions to problems. Yes. When the Americans changed government the other time, a lot of funding that came from the US to Uganda in healthcare services went off. And the question is, as Africans, how long are we going to be depending on Wazungu to handle our healthcare challenges? Doctor, at the end of her submission, she has been able to identify a key problem to food security in Kigezi sub-region. About 15 years ago, when we moved to conservation, and we thought we should have alternative sources of wood in order to reduce the pressure on the natural forests, everybody in Kigezi decided to plant eucalyptus and tapachura on the hills. Okay? Now, eucalyptus drains all the water. But before the water is drained, all the land has been covered with trees. And so food crop production somehow reduced. And this problem has been identified by a doctor. So I want to appreciate the role of science in problem identification and establishment of solutions. It is important that we integrate our scientific thinking in the world of medicine with these other worlds, agriculture, veterinary, in order for us to enhance a holistic approach to healthcare in this country.
The other issues to the Commissioner, some of our MCH indicators especially those maternal mortalities and perinatal deaths. We have an incomplete referral system.